This year at WCLC, I would have three major takeaways. The first one is in the targeted therapies, the KRAS G12C inhibitors. We have seen very interesting data on a new promising inhibitor, GDC-1636, results from the Phase I data, but with a very nice response rate. We will have to wait for the PFS. And also the combination of the first inhibitors, sotorasib plus SHP2, a bit disappointing, and sotorasib plus immunotherapy, where we can see that sometimes combining a targeted therapy and immunotherapy has its challenges. My second takeaway is on immunotherapy. We have seen interesting data on these hard-to-treat patients, those that recur after chemoimmunotherapy. It seems that STK11 is a subgroup where we should do better, maybe adding some antibody against CTLA4, but also with the HUDSON data and the possibility to re-challenge as a second line an immunotherapy plus a drug that increased sensitivity to immunotherapy. And we have seen also some interesting data on the re-challenge of pembrolizumab for those patients that receive as first line 2 years of pembrolizumab stopped because the patient was in response. In first line, pembrolizumab should be given only 2 years. We have some patients that are still on response, but might recur, for example, 4 years after that. And there, interesting data showing that there is a benefit with challenging immunotherapy in that case. My last takeaway is in the early stages. We see a very important study that has compared for the lesions less than 2 centimeters without node invasion, limited resection compared to lobectomy that shows that limited resection is a valid option. And obviously, my last comment would be on the perioperative immunotherapy, where we know that it's a very important field with a lot of new data and important overall survival data from atezolizumab and the IMpower10 study.